Okay, let's go ahead and get started. So hello, everyone. We appreciate you being here. So just a reminder that this is for the McGovern students counts as a fall dinner. So make sure that you get all of the required meetings that you attend. So before we begin, I want to make sure that we acknowledge some of our sponsors and some of our new partnerships. So we always have a fall and a spring lecture. This one is a little bit different, a little bit out of the ordinary, but something that we are very welcome and very excited to have here at the McGovern Center. We have a grant from Rice University from Bridge, and the partner in the grant is Dr. Kirsten Oster over at Rice, who is one of the directors there. If you have any medical humanity Rice needs at Rice, she's the go-to person. So great to have my partner in crime here. And so we have the McGovern Center, we have and the Bridge, both the Bridge Institution giving us the sponsorship. So we are very happy and very lucky to have Dr. Alyssa Burgart. She is a very busy person and for great reasons because she's awesome. So I'm going to introduce her and I am going to turn it over to her. We will have Q&A. Feel free to use the chat, but then also I want you all to unmute yourselves. Students will have first go at questions, and I know Dr. Burgart will welcome those questions. So I will, at the end, ask for students to unmute themselves or to put their question in the chat box. So let me introduce Dr. Alyssa Burgart. She is a clinical associate professor of pediatric anesthesiology at Stanford University School of Medicine. She specializes in anesthesia for pediatric liver and kidney transplants and trauma-informed anesthesia care. Dr. Burgart has a joint appointment in the Stanford Center for Biomedical Ethics, serves as the co-chair of the Lucille Packard Children's Hospital Ethics Committee, medical director of clinical ethics, and is a member of the Stanford Hospital Ethics Committee. She provides ethics consultation services for people of all ages and conditions. She holds both undergraduate and master's degrees in bioethics and health policy. Dr. Burgart is active on Twitter. I'll put her Twitter handle in the chat. You should definitely go follow her. She's awesome. And where she comments on anesthesiology, bioethics issues, and all things fun. So I will turn it over to you, Dr. Burgart.
Hi, thank you so much for having me. And I'm actually going to copy one little link over from my talk, and I'll paste that in the chat as well as give you all a QR code just momentarily. All right, so just tossing a little link in there that'll take you to the resources. So, if you're like me and you have a super short attention span, I just wanted to give you something very clear that you could distract yourself with. Okay, Dr. Ray, can you see my screen?
Yes, you are good to go. I'm going to try to mute these chimes as well while you're working. So yes.
Super, sounds great. And here we go. So, and I don't know why, there we go. So this is I put together this talk specifically for all of you. And it's a little bit unusual because it was sort of looking through all the work that I've done and how it is that how social media has played such an important part in helping me to develop my career and to develop and give me places to channel really a lot of the things that I love about the humanities and those sort of humanities skills in a digital age. So I called this Becoming a Social Physician, Embracing Modern Medical Humanities. And I think that physicians have been interested and healthcare providers have been interested in creative outlets for, it's a very human thing to want to do. And so I think that social media gives us a unique kind of new lens to look through that and to enhance our, the opportunities we might see for ourselves and others. So disclosures, there's no financial disclosures. I am a doctor and a bioethicist. I'm not a lawyer or an anthropologist. I don't have a degree in literature or anything else like that. And I'm going to just kind of tell you a story of how I've really embraced digital media for a couple of themes. health communication is something I feel very passionately about. Obviously, bioethics, I work with Dr. Ray really closely. Advocacy, professional collaboration, and fun. I think that we can be, me as a doctor, I can be a very serious person. And so I'm oftentimes looking for ways to find enjoyment in addition to the meaning that I make from being a physician. Before I became a bioethicist, before I became a physician, I was actually a professional actor. I was a child actor. It's how I paid the bills for my family for a period of time, and it was super fun. I loved being on the stage, and I loved doing stuff for the camera. And so in many of those ways, it's great to be an elder millennial because with an acting background, because I'm very prepared for a lot of the social media things that are available. So I'm going to talk a little bit about health communication. Twitter is this incredible way for you to make these little, micro blogs of things that are important to you. And there is no reason that we can't use that to improve health communication. And certainly we saw a lot of clinicians embrace this with the beginning of the COVID pandemic. We've also seen how it can be used to really promote misinformation and disinformation. And so for clinicians who are willing to go out and be more public facing in the work that they do, you can really share through, de-identified ethical stories and information that people beyond your regular community may appreciate. So for example, this was a number of years ago. I had read a story about families not accepting vitamin K injections for their babies. And unfortunately, I had been in a situation years prior to this where we had to do emergency brain surgery on a baby because they had had a bleed in their brain related to their lack of vitamin K. And so this is something that I've ended up doing a fair amount of communication on in the years since then, because it's an issue that continues to come up. Again, amplified by misinformation and disinformation. I'm super fortunate to be at Stanford, and it sounds like much like the resources that are available to you, Stanford has a number of humanities resources. There's a number of resources specifically for people who are into writing and storytelling. So I've been working with a group called the Pegasus Physician Writers for about 7 years. And that's a group where you can kind of get together with other clinicians and share your written work together. And that's been a wonderful opportunity. Additionally, I work with a woman that works here who's an author named Laurel Breitman, and work on physician storytelling. And through that, I also started doing storytelling coaching. And one of the things that's been really interesting that I hadn't really thought would be valuable about storytelling coaching is the way that it has helped me to understand the arc by assessing other people's stories. Understanding the arcs of those stories has made me a more effective writer, not only in the more traditional formats, but additionally in the social media sphere. And then this is just something that's available through the Pegasus Physician Group, which is, they started a journal called the Pegasus Review. So if any of you are looking to publish any nonfiction work, fiction work, or poetry, I suggest you check it out. Additionally, through some of my relationships online, I ended up meeting Emily Silverman, who is the host of the show The Nocturnists, which is a podcast as well as live storytelling program here in the Bay Area that's really come to national prominence through a number of their specific series of stories on healthcare providers. And so I'm actually featured in the current season that's on, which is called Shame in Medicine, The Lost Forest. And this has been a wonderful way to share the experiences of shame that are often present in medical education, in, when you've made an error, or you've been, an outcome has been unfortunate for a patient. And as clinicians, we often have such a strong affiliation of our identity, like who we are with our job, that can make this even more powerful. So I really enjoyed being part of this program, even if it was to talk about something that makes people uncomfortable. Bioethics obviously is a huge part of my life, and I get to hang out with Dr. Ray digitally and on the phone every week, basically, because together we co-edit Bioethics Today, which is the online free content that's available through the American Journal of Bioethics. And it's been fascinating going through this partnership with Dr. Ray, because, and additionally, I would say the more I edit, the more I learn from Dr. Ray, as well as from other kind of short form writers. I find that my own writing improves, my own writing becomes significantly more clarified. And so it's been really exciting to have that opportunity as an editor to additionally get that benefit I find in my own work. And it's fun. We get to like read a lot of cool stuff. We also get to turn down a lot of spam. Additionally, through the American Journal of Bioethics, I have had the pleasure of hosting 2 really phenomenal webinars, and I put both of those links in the resources page that I sent out, that I put in the chat. And the first one was with 3 legal and bioethics scholars who, this is before the Dobbs decision came out, and we were able to talk about what legal implications we expected to take place. And then the second one was about implications for health professionals. And so it was a wonderful conversation with an incredible reproductive justice nurse, Monica McLemore, a midwife, Stephanie Tillman, who's also a bioethicist doing her PhD currently in bioethics, as well as with a neonatologist who was able to talk about really the implications that this has, not only for pregnant patients, but additionally for the practice of neonatology and the practice of pediatrics. One of the ways I'm, in academics, oftentimes we are expected to publish. This is not usually what they have in mind. Usually the expectation for publications are in journals where you might write a very long piece. The time it takes to submit it and ever get it published can sometimes be months or longer. And I like dopamine, which is probably why I like social media so much. And so writing opinion editorials has given me an opportunity to have a larger audience. Many more people will read this work than folks who are necessarily going to be reading academic bioethics or academic anesthesiology journals. And so I've had the opportunity to publish some pieces on issues that are very important to me. So I've published a number of times on vaccination. This first one, teens with anti-vax parents, teens with anti-vax parents should have a right to be vaccinated. And this was before the pandemic. This is when we were so sweet. We were just worried about the measles. It was a different time. Now we can worry about the measles and COVID and the flu and everything else. And then I additionally was able to publish this piece in the Washington Post with Govind Prasad and Emily Largent, who are also both bioethicists in the Washington. And so we talked about the FDA's decision to delay vaccination for kids under 5. So it's a very fast moving process writing these. The turnaround is very, very quick. The standards are exceptionally high. And so it really does make you think very differently than when we publish through an academic journal. And one of the other things is, I'll talk more about collaboration later, but I met Govind through Twitter. So we just our circles hadn't really crossed in our academic spheres, but we met each other actually through social media, and through following each other's interests, realized that we shared a number of opinions, and that gave us the opportunity to publish this together. And that's how I met Emily, which is great. So you can make a bunch of real life friends, which is fun. I know that you all are young, so you're like, of course you can. Why aren't you talking like this? At the beginning of the pandemic, I was also able to publish a number of pieces related to the cancellation of elective surgeries. And this was something that was a hot topic. And I work in an operating room, and I was watching my own organization very closely to try to understand how were we going to handle this, the unprecedented beginning of the pandemic. And a number of areas were very eager to understand that, because it's a very unusual place. Not a lot of people understand how surgeries work and what's the difference between what's an emergency surgery, what's an elective surgery, what's an urgent surgery, and trying to figure out what that meant for people who needed those services. Additionally, I have a real interest for professional self-regulation. I think that the role of being a healthcare provider, the role of being a physician, yes, it's a job, but it's also, to me, I feel that we have a sacred duty to our patients. And part of that is ensuring that other people in the profession are also living up to those expectations of providing excellent patient care. And so when an anesthesiologist had been accused of potentially murdering a number of patients, my colleague, James Lozada, who's also an anesthesiologist, we got together and wrote this. James is also someone where, even though we're in a number of the same professional organizations, we actually also met through a social media connection. Same with, in terms of writing some things for my own professional organizations, the turnaround time for these is a little bit longer than for an opinion editorial, but it's still quite a bit faster than for a typical journal. And this has been a way for me to write about issues that I think are important for my professional colleagues within our much smaller circle of anesthesiologists. And so, I found that there was a number of issues that my colleague, Zachary Deutsch, who I also met through Twitter, he's an anesthesiologist in Florida, and we were able to put together this, he wanted to do an Ask the Expert, to talk to an ethicist about a number of issues that impact anesthesiologists. And it was really fun. It's really fun to put these things together with the people that you develop relationships with. And then recently, I just had this piece come out on safety reporting and professionalism reporting through hospital systems. And, when is it that we use those things to help promote patient safety versus when is it that those are being used for retribution? When is it that there is bias being perpetuated against people, whether it's for gender or race or ableism, or what are all the things that may be contributing to that? Or simply the fact that you have people who dislike each other who may utilize these reporting systems as a form of retribution. And then we really wanted to have more people talking about this issue of DARVO, which is where the person who has perpetuated the harassment may deny that, attack the victim, and try to put all of the blame onto the victim. And the person that I wrote this with is my colleague, Dr. Stephen Bradley, who, interestingly, I did meet through Twitter. He's also an anesthesiologist, but we met through playing music, and I'll get to that in a little bit, also through Twitter. And so you can kind of get the sense from some of the things I've already shown you that advocacy is a main thing that I'm interested in doing, because I think it's important in my role as a physician to ensure that I'm doing things I can to advocate for my patients. And for me, the humanities provide a really important conduit for that, because when I think about the things that make me want to be a doctor and make me want to take care of human beings, those are also the things that lead into the humanities. And what does it mean for us to be human, and what is it about the human condition that we want to explore? And advocacy turns out to be a really wonderful outlet for those things for me personally. And so I've done quite a bit of disability advocacy. I would say that when I started following Alice Wong on Twitter back in 2016, when I first joined the platform, she at the time had a project called Disability Visibility that I'll give you a little bit more information about later as well. And I just sort of had this ability to sort of watch the disability community within Twitter have these conversations about things that were important to them. And it really brought this important perspective that I just wasn't getting as a clinician. We are oftentimes we're a position of hierarchy, we're in a position of authority, we're in a position of social power. And so these were perspectives that I was missing. And so I ended up getting to know Alice over the years. And then during COVID, was delighted to have an opportunity to help promote High Risk Californians, which was trying to get vaccine access for people with disabilities in California, because originally the state's plan was to solely release vaccination on the basis of age. And that meant that you might have somebody who was 30 years old but had a really serious health condition that placed them at high risk, and the data showed that, but those folks were not going to get access to vaccination as early. as others. And so I worked with Alice, and we had a number of like parallel processes that we were doing with the community to try to get more attention on this issue. And thankfully, we were able to get a number of journalists interested in this issue and talking about the issue of vaccine access. And I was able to put together a letter that I asked healthcare providers to sign if they were in support of their patients with disabilities having access to vaccination earlier. And we were able, in the period of about 48 hours, to get about 400 signatures and take those to the state. And actually, through this advocacy work, not only were we successful at getting the governor's attention and the California Department of Public Health's attention, they actually asked me and a number of other folks who were working on that to be on the committee that would talk about vaccine rollouts and other disability-related issues. And so it was a really interesting arc to be on, to then have that ability to influence the state's policies through people I had met through social media. Reproductive justice is something that I'm also incredibly passionate about. And so I didn't realize in May and June that this is what I would spend a lot of time doing, but the group that one of my professional organizations, the American Society of Anesthesiologists, was pretty determined to not say anything about the Dobbs decision, despite the fact that there were clearly going to be legal ramifications for physicians. We were going to have physicians who would be experiencing moral distress in not being able to provide evidence-based care to their patients. But additionally, there's a lot of people who are capable of getting pregnant who also happen to be anesthesiologists. And so really trying to help the organization realize that this one was about patients, but additionally, it was about our own members and what did that mean and how did the organization, how was the organization going to reckon with that reality? And so one of the things that we ended up doing is I partnered with a number of other really amazing women anesthesiologists, and we were able to publish this piece trying to help folks understand why it was that anesthesiologists needed to care about the Dobbs decision. And we were thankfully able to get this placed in MedPage Today, which is one of the highest read medical kind of daily websites. For professional collaboration, like I said, there's a lot of overlap here because there's many different areas in which these things overlap. It's been really fun getting, like I said, getting to know people. And Dr. Canaris is a pediatric intensive care unit doctor in the UK who is also an ethicist and reached out to me. And we had just been chatting in the background about our ethics interests and our interests in terms of pediatric medicine. And we started having this conversation around patients who are potentially intubated but not sufficiently sedated. And, you know, how often was this happening, and started to do some more research into that. And Dr. Canaris brought in his colleague, Dr. Intensive Care Unit trainee at the time. And it was really great to get to know both of them and to put together this paper and to really start trying to have this topic discussed more often, because I think it's a much bigger issue and has a lot of implications that we otherwise probably haven't been discussing sufficiently in the critical care community and in the anesthesiology community. I think in anesthesiology, we sort of already think of this as a never event, and it's something that we are very conditioned throughout our training to never use these paralyzing medications without sedation, but realizing that it can be somewhat more complicated in the intensive care unit as well as in pre-hospital care. So being treated by ENTs, for example. It's interesting as well to watch through the lens of social media. You kind of see certain issues come up. And it was interesting, I saw this, there was a study that came out in the Journal of Vascular Surgery that had analyzed the social media content of a number of recent graduates. They had not gotten the permission of any of these graduates or notified them in any way that this would be done. The the content of all of these folks' social media accounts were reviewed by 3 young men, none of whom it seemed had thought in any way about the various biases that may be introduced into the way they were analyzing this information. And essentially, it was actually like a garbage repeat paper of a previously terribly done paper in a different surgery journal a number of years before. And so I was almost surprised when I read the vascular surgery piece, because I was like, oh, this is like the same poorly done science that I saw in another study. And this one just happened to, hit the zeitgeist. And suddenly, one of the things that was reported in this study was that it was unprofessional, that women were determined to be unprofessional if they were wearing swimsuits in their pictures. So even if someone was like holding an alcoholic beverage in an image, it was considered unprofessional. But this group did not actually assess, were any of the statements that were made racist or sexist? They weren't looking at, were there other behaviors that were being demonstrated that are inherently unethical, not just, a white-centered version of professionalism. And so it was really fun to work with my colleague, Tricia Pendergrast, who's I first met her when she was she was working in a laboratory in an ICU in Chicago with a number of ethicists that I knew there, who were also pediatric intensive care unit doctors. And then Tricia went to medical school. And so as a medical student, I got to write this letter to the editor with her, really outlining the concerns that we had, which was that, if your journal does not understand social science and does not understand how to appropriately critique social science, then you have no business trying to publish those. So you either need to reach out and get peer reviewers to understand what's going on, or you need to be much more selective about the work that you're willing to publish. And so we were grateful to the Journal of Vascular Surgery for very quickly publishing our criticism. One of the things I love doing at Stanford is working with Stanford Medicine and the Muse, which is our big medical humanities program here. And I really enjoyed, we have something called the Medical Student Symposium, and this is where students are able to share, there's extensive artwork that they are able to share. We have, in the past, we used to have a gallery. Since COVID, we've had a digital gallery. We additionally will have readings of poetry and short fiction and nonfiction that our medical students have created. So it's a really medical student run and medical student designed program. And we always try to get somebody, some impressive person. And thankfully, like I said, I had met Emily through from the Nocturnist through social media. And we were very grateful to her for accepting our offer. And she came here to Stanford to give a really lovely talk about how she came up with the Nocturnist and the kind of outlet that it's creating for clinicians. Additionally, I do all of the art for our social media content on Instagram for Stanford Medicine and the Muse. And one of the things that I'll put together is we have something called the Kalanithi Writing Awards, which is from the surgeon who's passed away named Paul Kalanithi, who wrote When Breath Becomes Air, which is a beautiful book if you have not already read it. And for each of the finalist pieces, I just started making these for fun because I wanted to have something to put up on our Instagram page. And I found I like making pretty things. And but apparently the authors think of these as like their unofficial prizes. So we've started. I'm continuing to make them, I guess, year after year, and it's quite fun to try to make something special to memorialize their award in addition to the physical award they get. Like I said, we can be serious people, and so I am always trying to find ways to enjoy myself and suffuse some joy in my life. During the pandemic, I ended up becoming friends with this sort of ragtag group of burned out doctors and healthcare workers. And we started calling ourselves Docs Who Rock, and we started just playing music that we enjoyed and being very intentional, that it didn't need to be perfect, that the point was to just have fun, and that our audience was really each other. But we found that it was something that a lot of folks enjoyed. And so actually over the years since 2020, when we started doing this, the group of clinicians, physicians and nurses and EMTs who will post videos has been really, really fun. And I love the amateurism. And some folks, despite being, they're busy with their clinical lives, are, exceptional musicians and exceptional singers, and it's really fun. And so this is actually my friend, Stephen Bradley, that I ended up writing the paper about retribution with, and we actually met through playing music. We didn't meet through anesthesiology, but it's been such a wonderful, it's been a wonderful way to get to know people. I'm going to show this little video. This is I started writing more music. I love to play guitar. I've been in a couple of bands. I'm very amateur. I'm self-taught guitarist. But this was from a Stanford Medicine and the Muse event. Just kidding. I'll just show it there's a link in the resources. Unfortunately, it's telling me I have an error and I can't share it to you. I don't know why. But this, when I wrote the piece originally, before I posted it, I just sent something out to Twitter and said, hey, if you all have photos of yourselves in your PPE, healthcare workers, just send me a DM with your photos of you wearing your PPE. And I ended up receiving many, many photos, and was able to make a montage. And so as I play the song, and this was right when the Delta wave was first coming out, and people were just exhausted and understaffed and all of that. It ended up being really powerful to have all these photos of people that I know very closely, but also a bunch of people who are ultimately strangers to me, and connecting over their willingness to share their photographs. This physician actually sent me two. She sent the one that's in the video right before this is her much earlier in her pregnancy, and she ended up working until quite close to delivery because they were so short-staffed in her ICU. And then before the pandemic, I used to go present at conferences where my friends who are musicians were presenting. So I presented at a bunch of chemistry conferences, because I guess they like it when doctors come talk to them. So this is my friend Brian. We have known each other since we were about 19. We worked at a ranch together when we were much younger. And we used to be in a band together, and now we get together and play shows every now and then when we're able to. And I was just able to see, this is my friend Steve. He's a pathologist in Philadelphia, and my friend Randy, who's a scientist in Indiana, and my friend Russ, who's another scientist out on the East Coast. And so we all were able to get together for the first time since the pandemic, just a couple weeks ago, and it was super fun. Two of these guys also have had transplants, so the nice thing is, I always know the COVID protocols are going to be awesome, because we don't want any of them to get sick, especially. So we played a couple of outdoor shows in North Carolina. It was pretty fun. There we go. I'm going to take you all through just some people who inspire me, who I think are just doing cool work and are people that I learn from and that I really appreciate. One of them is Dr. Kimberly Manning, who is an internal medicine physician at Grady Hospital in Atlanta. She is an absolutely gifted storyteller. She has these beautiful threads that she uses to illustrate the relationships that she builds with patients, and the ways that she's such an effective communicator, and she's so effective at using listening when listening is indicated, and using talking when talking is indicated, to really connect with her patients. So if that's something that sounds interesting to you, I just cannot recommend her enough. She's a brilliant woman. Dr. Jennifer Gunter is an obstetrician gynecologist who has really, she's written a number of books over the years, and it's been really exciting to watch more and more people find her and find her work. She kept a very active blog for many, many years. Now she has a Substack. She was a writer for the New York Times pretty frequently for a while, specifically on women's health issues and obstetric and gynecologic issues. And she's got a great sense of humor. She's a fierce advocate for her patients and her family. Arga Gonzalez is a personal friend of mine, but we actually originally met before she came back to Stanford through Twitter. She does a lot of work with the media. She's currently with our Department of Internal Medicine doing a lot of gender equity work and trying to support non-performative DEI work here at the university, which I really appreciate. And she also does work with the Clayman Institute, which is our gender study institute here at Stanford. Ryan Marino is a emergency medicine trained toxicologist, and I feel like if I had not been an anesthesiologist, I should have been a toxicologist, because I love that. So I enjoy following a number of people in toxicology. And one of the things that I really appreciate about Ryan is he talks really openly about his brother's death from a drug overdose. And I know that my life has been touched by people that I love who have suffered, unfortunately, from addiction. So he's really great about talking about that and really destigmatizing the use of drugs and folks who have relationships with drugs that are potentially harmful, and trying to really remove that bias from the way that we talk about our patients. I think I'm from the war on drugs era of DARE training and things like that, and the villainization of people who use drugs, and I think we see now how very, very harmful that has been. Rana Oddish, incredible. If you haven't read her book In Shock, I highly recommend it. It's a beautiful book about her experience as an intensive care unit physician when she was pregnant, suffering a severe complication and almost dying multiple times, actually. She writes really beautifully about her experiences as a physician, as well as her experience as a patient. She's also an avid painter, and so she'll frequently share the art that she makes, which she also, in addition to it being beautiful and interesting, she finds incredibly therapeutic. Chase Anderson is a UCSF. He just recently finished his training in pediatric psychiatry. He's wonderful. He calls himself a Rainbow Phoenix psychiatrist, and he's just all about sharing his love for other people, sharing his hopes for people to have positive experiences, and he's just an incredibly positive person. And it's always often quite lovely to come across his tweets, because he's somebody who's really out there trying to make the world a better place. Dr. Gluckalman-Flecken, it's so fascinating. I feel like when I started he's an ophthalmologist, but he's also a comedian, and I just watched him really come up with new ways to share videos, and he comes up with very funny but tongue-in-cheek ways to convey kind of, I think, the irritation that many of us feel about some of the issues in medicine. I think it's a real gift, and anytime you can make somebody laugh, it's particularly can really be joyful. And I talked earlier about disability advocacy, and so I'm going to share a couple of folks who are, just a few, but people who have really inspired me and really helped me to expand my thinking on disability, but who aren't physicians. Imani Barbaran she goes by Crutches and Spice, which I think is hilarious, and she's just very open and about talking about ableism and the impact of that on her life, and again, I think does that in a way that is very authentic and very interesting, and it makes it so that I feel like I've, again, learned so much from her about, what are the things that people with disabilities know that the rest of us actually should be paying much better attention to. Matt Cortland is he's a lawyer who's chronically ill as well, and they are really excellent about talking about the impact of, again, they're not only being a disabled person, but additionally their experience understanding disability law and being a disability advocate and recognizing, understanding not only as a lawyer, but also as a user of some of these services, and what are the shortcomings of a number of the resources that we have for people with disabilities or people with chronic health conditions. And so I consistently learn so much from Matt, and I'm so grateful to them for their sharing their knowledge really persistently. And then Alice Wong, who I mentioned earlier, she had a book that came out a number of years ago called Disability Visibility. She also has a website of the same name and had a podcast for a while. One of the things, especially for the folks who are medical students, and I hadn't thought to put this in the resources, but I can try to add it. She was unfortunately recently hospitalized and needed to have a tracheostomy and a G-tube placed, and wrote really extensively about it on the Disability Visibility website, and gave a lot of detailed account really about, the ways that her family was trying to weigh decisions and the ways that her care was going to change so dramatically over this, because previously she has a neuromuscular condition, which means she progressively gets weaker over time. And so for many years, she was able to breathe with something called a nasal BiPAP, which just meant that she had this little mask that went over her nose. She was able to speak, she was able to eat. And unfortunately, needing to have a tracheostomy has really changed that. And so she's no longer able to eat by mouth, and she's no longer, well, currently, hopefully that will change a little bit, but, and no longer is able to like smell food because she's no longer breathing through her nose. So her memoir just came out recently called Year of the Tiger: An Activist Life, and it's absolutely beautiful, and I highly recommend it. So if that's something that you're interested in learning more about, this would be, Alice's work is a great place to start. So I put my email up here, and you're all welcome to reach out to me at any point. And if you missed that link I put in the chat earlier, you can also scan this QR code. And I'll just leave this up for maybe another, maybe 30 seconds to a minute. And then I'm excited to chat. I feel like I did a lot of talking, and give all of you the opportunity to talk.
So like we said, we're going to give students first dibs at questions. We have McGovern Center students and we have Rice students. So anyone have a question for Dr. Burgart? Alex, go ahead.
Hi, thank you so much for that talk. I thought it was great. It's great to hear about your career and kind of, where it's led you and what topics you found yourself interested in working in. I think it's really interesting to see how you really can do a lot. You're not really confined to a certain topic, and you've been able to kind of go where your interest is and where you can find those collaborations. So that's very exciting to hear. As someone with a short attention span and many interests. So my question, and I have two if we have time and no one else has any, but the one that I care the most is a little bit about my thesis project. So right now I'm kind of still forming it, but I'm looking at the debate, which has been a long debate, on the right of the physician to refuse to treat a patient versus our duty to do so. And how I phrase that might tell you where I land. I feel it's our duty to do so, right? And so I've been reading a lot of the justifications, where their weaknesses and strengths are. And one thing that I found really alarming in this research was that the AMA's like official codes of ethics include a statement that I believe it's physicians have the right to choose whom they will treat in non-emergencies, right? And that was an inclusion in 1987. So not something that was a part of our professional ethos prior to that. And so I am curious, so I'm looking at this in the context of COVID-19 and HIV, where HIV spurred a lot of this discussion, right? And I'm arguing essentially that perception of like moral danger rather than just fear of infection for some is a bigger impetus to try and assert their like personal conviction, right? Rather than that like fear of death, right? Where a lot of us kind of, when we enter this field, we understand that we have a higher risk than the general population. And so my question is, as this pertains to things like abortion and abortion access. So I've heard many OB-GYNs, for example, who are personally pro-life, who would advocate for lack of access, right? Or would refuse to perform those procedures. Alternatively, you can have physicians who would refuse to treat patients that are HIV positive, refuse to treat or create a disability accessible environment in their clinic. And so I'm wondering what your thoughts are on how social media interacts with that concept and how it might kind of create an easier way for individuals to like assert their own autonomy over their professional duty.
Well, Alex, I love that you came out of the gate and you were like, let's get uncomfortable. Let's get it.
Sorry.
Yeah, I mean, it's a great question. And I think one of the things that, this idea of conscientious objection, when is it if my moral compass says I need to not participate in this particular activity, when do I have the ability to do so and under what conditions? And the AMA statement is absolutely not perfect. I will say it is much more restrictive than what most states actually allow clinicians to do. States oftentimes do not articulate that in an emergency, for example, you actually do need to ensure the patient has access to that life-saving care, and that your duty to the patient should supersede whatever your other problem is. What we've seen in relation to a number of care items is, for example, the application of this, for example, by like pharmacists who are like, oh, well, I'm a pro-life pharmacist or I'm anti-contraception, so I'm not willing to fill your contraception prescription. It doesn't matter that a licensed person provided that prescription. It doesn't matter that the patient has consented to receiving that care and has come to pick up the prescription. And if there's only one pharmacist there, you might not be able to get access to that medication. And we're seeing this as well around we're seeing this additionally around other medications related to abortion, where in states where there is a greater restriction placed on abortion access, we're additionally seeing restrictions placed on medications that might cause toxicity to a fetus, whether or not the patient is actually pregnant at the time. So I think we're seeing this through a lot of different things. We're seeing this in the provision of, gender affirming care, the provision of hormone therapy for the same reasons. We're additionally seeing, we see this in California. We have something called the End of Life Option Act, which is where you can have physician aided dying for patients who are already dying of another cause. And so much like clinicians being able to opt out of providing abortion services, clinicians can opt out of participating in End of Life Option Act. What we require at our organization is we actually have a policy that actually outlines what the clinician's responsibilities are. And so clinicians are made aware that these are their obligations. And that's something that's incredibly important. We don't see, in my practice, I don't tend to see folks anymore who refuse to take care of patients who are HIV positive. And part of it, what you get to is, it was a very different time in the 80s. And even when I was training in medical school, while HIV was getting more treatable, it's significantly better today, as long as people actually have access to that care. So I think you're touching on a really important issue. There's actually an entire American Journal of Bioethics edition that is all about conscientious objection, and specifically talking about the role of organizations like the Catholic Church. I trained at a Catholic hospital. I considered not going there, but decided it was where I was going to train. And so, my employer wouldn't pay for my contraception. My employer, I had to get different insurance. I bought my IUD from Canada. Like, there's all sorts of things that we end up doing in order, and that's from an organization that they don't actually care what the clinicians have to say. They actually put in the clinician's contract, you cannot provide this care because you are at a Catholic hospital. So you're going to have no shortage of things to talk about.
Certainly not. No, and I think the thing that makes modern HIV treatment different, as well as was the Bragdon case in the Supreme Court, where those living with HIV were considered under the American Disabilities Act, right? And prior to that, there were some really I've been very surprised. I knew that this kind of discussion existed. I had read on it previously, but some of the op-eds that physicians put their names on were pretty mask off in terms of their bigotry and hatred. So it's really startling,
and
right?
And this is the other thing I think is relevant, and this is something that I've struggled with is, I provide gender affirming care. I feel great about the fact that I do that. And I'm so sorry. My child is hammer texting me, and I'm just trying to make sure she's okay.
Oh, that's sweet.
It's great when your children learn how to text.
Yeah.
So, this is one of the things that I've really struggled with is that, I want our transgender patients who present here to receive care. I want them to receive excellent care, and I don't want them to receive care from somebody who is going to dead name them or refuse to use the correct pronouns or whatever. And so in that sense, I don't want clinicians to feel forced to provide care to somebody that they don't respect. And I don't think that the answer to that is making people provide care that they don't feel comfortable with. I think those are bigger societal issues that we are not going to fix with that particular mechanism, at least not in the United States, where we have exceptional protections, legal protections for people who have religious objections, for example, to providing certain services. So I have mixed feelings about it, because I also think it's important that we protect patients from being exposed to people who inherently disrespect them.
Well, and also
Let's get
protect
another question.
physicians. Sorry.
Go ahead. No, you can. Right.
And then
No,
I'll
you can
be
ask
quiet.
me.
I can talk a lot. Sorry.
Okay. Yes. Let's just go. Say what you have to say, and then we'll get another question.
Okay. I think it's important to protect physicians from patients who are discriminatory as well. So I think it's important that physicians who are minorities be allowed to transfer care of their patients to others if those patients are going to, hurl slurs at them or be unsafe, right?
Yeah,
Great.
and there's been some great work on that, demonstrating sort of a thought process of how do you address patients who express those sorts of beliefs towards clinicians, and how do you keep clinicians safe? Yeah, absolutely.
Great. Thanks, Alex. Next question. Who has a question? Feel free to unmute yourself.
Hi, thank you so much for that talk. It was great. My name is Anna. I am unmuting because I know you just now mentioned your experience working at a Catholic location and how that kind of influenced some of your life choices and other things you had to do. Now, please, don't hold this as fact. This is a rumor that I've heard, but I've heard the rumor that to be a physician at UT Physicians, which is our school affiliated physicians, correct? That you have to sign a document if you've been hired in more recent years saying that you will not provide abortion care regardless of what field you're in. And that was extremely concerning to me when I heard that rumor from a physician who said that she conveniently never turned in that part of her contract. And so I was wondering if you had experienced anything along those lines outside of your work, specifically with a Catholic organization. And if so, what kind of steps you take to combat that, because it's not necessarily a religious objection to providing care.
Yeah, I mean, I don't know about this hospital. I don't know anything about their contracts. I think that when clinicians are considering engaging in a contract relationship with an organization, they should understand what strings are being attached to that. And the contract that I have with Stanford says that I will follow our code of conduct, and I will turn in a bunch of training, and there's a bunch of other things that are also part of these. for me as a clinician, I have decided to work at organizations that are whose policies are in alignment with my values and the type of care that I want to provide. So as an individual clinician, when you're trying to find a job, these are the things that you have to think about. Is this a place that I'm willing to work, and under what circumstances would I or would I not?
Great. Thank you. Appreciate that. Anyone else? We have a few more minutes. We can open up to faculty if you have questions as well now.
I've got a quick question, if that's okay.
Great. Go ahead, Megan.
Yeah, so thank you so much, Dr. Burgart, for presenting your perspective on all of these really salient and relevant topics. So as a very different question, I was just wondering, in terms of social media with Twitter, you know, I'm blown away by all the really wonderful collaborations that you've been able to sort of manifest from meeting people on there and all the connections and everything. I don't personally use social media that much as an aspiring academic physician. I know it's kind of almost like a necessity for me to have a med Twitter at some point, lest I miss out on all these really wonderful opportunities. But I was
you
just
don't
wondering
have to.
how you.
It's okay.
I feel that, you know, there's so many wonderful people on Twitter. I must, but I just wanted to ask how you, what your perspective is on kind of putting yourself out there, especially with things like writing op-eds and really kind of getting out of maybe this feeling of, I don't know if you ever experienced sort of like the self-consciousness of like, oh, my writing's out there for all the public to read, and I'm trying to reach out to all these like people that are really wonderfully accomplished and things like that. So I wonder how you kind of go about doing what you do on a daily basis and very successfully as well.
Yeah, well, one, I'm super vain and I love to see my name in print. So that is a great motivator. I think it's, you know, I like the immediate feedback. I find using traditional academic publishing, which, you know, of course I publish in those spheres as well, but like it's tedious, and there's a lot of just, there are certain elements of it that are not my favorite. And so this provides other ways of thinking about it. What I will say is, one, you don't have to do social media if it's not your thing. Don't waste your time doing anything that is not like filling your cup and bringing you joy. Like, there are real problems in this world, and whether or not you choose to like go on some dumb app that somebody came up with, it's not even going to exist in 10 years. Like, who cares? Don't worry about it. You know, you'll figure out the ways to meet people that feel authentic and feel right to you, and that's fine. What I will say is that whether you choose to be a public-facing physician on purpose doesn't mean that you won't accidentally be a public-facing physician. Many licensing boards and things like that release certain data. It's much easier for people to find where all of us live than it ever used to be. Patients may come looking for you for, you know, for a variety of reasons. So I think one of the things that I take particularly seriously is my my physical and digital safety. And certainly when you first start using social media, that digital safety is not as pressing, but I actually did put in an anti-doxing guide into the resources just in general for people to understand. If you're doing advocacy work, if you're doing online work, if you're publishing on controversial issues, it's just really important that you take your safety quite seriously.
Thank you. So one last question. Faculty, if you have anything, students, open up. So I have a last question. So for our Doctoring 1 course, our MS1s, I do the social media and medical students lecture, and it's actually coming up next week on the 18th. What is something that you would want medical students to know about using social media and patient privacy?
Oh, Keisha,
The hard-hitting
questions. I didn't even have to plant you. Well, I'm really glad we're talking about this. I think that, especially with this sort of like shock jock 24-hour news cycle, social media is definitely a place where you go to like purposefully attempt to get attention. And I think that people figure out pretty quickly that things that are gross or things that are, you know, weird get more attention than maybe the more banal aspects of our jobs. And I would say that I always imagine, if my patient were to read this, would they know it was them? If any patient were to read this, would they have reason not to trust me? Or would they have reason to believe that I would not value their confidentiality? And to me, confidentiality is a sacred duty. HIPAA, that is a floor. Privacy, federal privacy law that's the minimum. That is a minimum. And so to me, I would never want anything I put online to jeopardize my relationship with the real life people who I'm trying to take care of.
Right. I appreciate that. I'm going to repeat that in class, and I will quote you. All right, thank you, everyone. Let's join me in thanking Dr. Burgart for giving our fall lecture. We appreciate it. This is our first event from Dr. Oster's and I's grant, so it was a great kickoff. So everyone, don't worry about attendance. We have all of your participant list, so don't worry about that. But we appreciate you, Dr. Burgart. See everyone. I put all of the Twitter handles in the chat that she mentioned, so they are all listed there that you can copy and paste. I also put Dr. Burgart's Twitter handle there and repeated the link that she sent you all to. So just go in there. I will put it in one more time so you all can have that. But everyone, have a good evening. Be safe. There's the link again. All right. Thank you, everyone.
Awesome.
Dr. Burgart, I'll
Thanks
be
for
in
the
touch via email.
Okay. Thanks for the invitation. Bye,
No
everybody.
problem. Bye.